must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hi, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm your host, Stephanie Wyrock, and today we're doing a unique episode. And as many of you know, we talk a lot on this podcast about the burden of student debt across medicine, across physical therapy. And then another part of us, however, is that many of our patients also face high amounts of debt burden. We as healthcare providers aren't isolated to this. And they get this debt burden from actually coming to see this. This can really impact continuity of care and access to care. And so here at HET, we really were attracted to innovations here in healthcare. And so today we are joined by Robert Goff, who is a member of the board of directors of a debt forgiveness nonprofit called RIP Medical Debt. RIP Medical Debt has forgiven over $500 million worth of medical debt in the United States and has helped over 250,000 people across the country. So I'm going to tell you a little bit about Robert. He's had more than 40 years of experience in the healthcare industry, and he's a recognized expert in care delivery, organization, and financing. His career spans a wide range of leadership positions as a hospital administrator, managed care executive, consultant, regulator, and association executive. So he has a pretty unique perspective. He's held an academic posting as an adjunct professor in managed care and healthcare strategic planning at New School University in New York. And he's a frequent lecturer to physicians and community organizations. He's an entrepreneur who's helped develop numerous healthcare businesses, including one of the first for-profit HMOs in New York State, one of the earliest physician practice management companies, a chain of urgent care centers, the first network model Medicare and Medicaid managed care plans in a secondary market, plus provider-based healthcare business initiatives. He recently retired from service as the executive director and CEO of University Physicians Network, LLC in New York City. So you can see he has a unique perspective. And Robert, thank you so much for joining us today. We're so excited to have you on this podcast. One of the things when I was kind of exploring the idea of doing this podcast today, this episode, was I was really attracted to the very diverse and unique career that you've had. So I'm really interested to know a little bit more about yourself and how you got to where you are today.
Well, first off, thank you so much for having me on. I'm very happy to join you this morning. And one of the things that I've always taken the position of is information is the only thing that you can give away and still keep. So anything that I can share, I've always been happy to share. I got involved in healthcare back when I was in college, went to Northeastern University in Boston, which has a co-op education program, and hooked up with a position with Waltham Hospital in Waltham, Mass. And that got me into healthcare. The hospital administrator had been faculty at Columbia University's master's program in healthcare administration. And he was wise enough to advise me not to get a master's in hospital administration, but to get an MBA and apply it into healthcare. And that's really what I have done. I did a stint with the federal government involved with the old PSRO program, reviewing care that was given to Medicare and Medicaid patients. Went on to become involved with the Hospital Association, did that work as well. I had the experience as a hospital administrator of actually acquiring and closing and converting another hospital. Actually, it's one of, I consider, personal success stories, because not only was every physician accommodated in terms of hospital privileges, but we found jobs for all but 4 of the employees on the staff of that hospital. And the building itself was converted and continues today to be a healthcare facility. So we kind of did all the things of good reuse of the facility and took care of the people involved. Very interesting experience closing a hospital. I've actually been involved in about a half a dozen hospital closures in New York. We started the HMO. I got basically the HMO came out of a study that we did at the hospital that kind of the bug bit me in terms of what HMOs were, what managed care could do. And I hooked up then with what became WellCare, which is now a nationally traded HMO. And we founded that and had some very interesting time developing that. After that stint, became involved with the group of physicians in New York City, University Physicians Network, probably the finest group of physicians I've ever come across. These physicians largely had academic appointments. They literally were more concerned about patient care than anything else. One of the things that I've noticed and became very much involved with is the struggles that are occurring for practitioners. Institutions have a monopoly or an oligarchy situation. They command a market share by way of a license from the state. They also have access to funds to handle their debts, their unpaid bills, and always have the ability to raise money as well. The practitioner, whether it's a physical therapist, whether it's an independent primary care physician or independent physician of any kind, they do not have that luxury. We have physicians in a very odd situation where their heart is telling them, I want to provide care. Yet their head is telling them, if I don't collect on this care, I go out of business. And one of the factors that is really moving to drive physicians and other practitioners out of private practice is the issue of medical debt and the cost of operating a practice. So one of the reasons that you see physicians and other practitioners avoiding certain geographic areas is because they can't make a living. The debt is too great. The patients don't have the ability to pay. Now, what's really made things even worse for the practitioner has been the deductible situation. There was a time that the deductibles were very, let's say, affordable. A couple $100 a year, $500 a year. The average deductibles are now close to $2,000 a year. Well, that deductible and the economics of collecting that deductible from the patient is really visited on the physician. It's not on the hospital. By the time a patient hits the hospital, they've met their deductible. So that means that the deductible is something that the practitioners have to pursue in order to keep their doors open. The problem is that Federal Reserve did a study and found that 47% of Americans couldn't come up with $400 in an emergency without selling assets. And the average cash reserves of a household with the average income in this country is basically less than what the deductible is. So we're putting people who have insurance, who thought they were protected, who thought they had access to coverage for their care, in a situation where they are put under a great deal of economic strain. But where is that friction being visited? It's being visited between the physician and the patient. Now that changes the relationship dramatically. It also erodes the economics of the private practitioner, which is one of the leading reasons that practitioners are moving into employed situations with hospitals. Now, you can say, so what? What's the problem? Well, the problem that comes up is that care provided by employed physicians can run 20 to 40% more costly than the same care provided by physicians in private practice. So what we've done is we've driven up healthcare costs dramatically in the process. It gets visited on the patient, not only by a continuation of the deductible, but the patient also finds a few other things that occur in that situation. First off, many times the employed physician, who they may have seen as a private practitioner, haven't moved their office, but because it's now owned by the hospital, now not only is there deductible or copay for the visit, but there'll be a facility fee on top. And that radiology procedure where the independent physician used to send it to the independent radiologist now is sent to the hospital. Now, hospital imaging is easily 200-300% more costly than the independent radiologist service. And lab services can easily run 300 to 800% higher. So what we've done is we've now not only shifted the relationship, but we've now driven up healthcare costs in the process. I became very involved with this situation because I could see that the physicians are struggling to keep in private practice, to maintain that patient-physician relationship, to be able to make the referrals to where they thought was best care, to where they're saying, for my own survival, I have to move to an employment situation, and then they become part of this hospital system. And with continued consolidation of hospital systems is a major cause of driving up the expenses of healthcare. And as we drive up the expenses, that just transfers into higher premiums. Higher premiums are then borne by employers, who then say, well, I can't take this premium, so I'm going to download part of that cost increase to the patient in higher copays and deductibles and higher payroll deductions. So you see, I went through this with my son, who had the experience of his employer giving him a nice raise, which was more than 100% of the increase was eaten up by the increase in payroll deduction. And so you see this kind of ridiculous economic situation continuing and nobody putting a brake on. Now, if you're going to take a look at healthcare and healthcare costs, the answer is the answer that too many people have is, let's nationalize healthcare. Let's just take and turn it over to the government. I have a great deal of an issue with that. One, it's too easy, it's simple, and all it does is maintain the status quo. It will institutionalize a system that is far too costly. The reason healthcare is as costly it is it is dominated by the most expensive component, the acute care institution, these major institutions. Any other industry, if there were real commitment to healthcare, actually health, would look at how do you build a system that intervenes early on in a healthcare incident and then treat it at the facility that has the least cost and the least restrictive environment. Now, a lot of factors go into that. We all talk about healthcare and healthcare costs, and this is terrible, but we have to step back to realize what's creating those costs. And this is where we get into the area of what are called social determinants of health. What are the things in an individual's life that are contributing to their ill health? And let's get good at, one, addressing those, and then the treatment that people still need, how do we address it in the least costly environment? So I will give you an example. Along the way, I became a dialysis technician. And dialysis in this country is largely institutional based. It doesn't have to be. It can be home based. I did dialysis at home. To me, the costs go down dramatically, the quality goes up. But because of the reimbursement structure that we've created, where it is more economically beneficial to keep a person in an institution being dialyzed, we haven't developed home dialysis the way we should. Right? Involved with a company now that has moved to telemedicine as well as home visits, a combination for chronically ill. Their people who are enrolled with their program literally are staying out of hospitals because they have instant access to physician by telemedicine with a backup of a home visit, in which case they're avoiding emergency room visits and hospitalizations, reducing the cost dramatically. We have a home managed long-term home care company that I sit on the board of. This is a company that for less than half of what it costs to keep a person in a nursing home, keeps people at home rather than institutionalizing them in a nursing home. These type of models have to be employed across the entire healthcare spectrum. But what does that mean? That means we have to find the money. Well, the answer for most people is we don't want to put any more money into healthcare. And I understand that. The answer then is to take the money away from the acute care situation. Now, hospitals will always say, if you take the money away from me, we will close. Yeah, there will be hospital closures. But hospital closures does not mean a denial of access to care. Hospital closures that are planned with alternatives means actually an increase in access to care. This is one of the problems that we have, is the forces that are in place in healthcare to maintain the status quo. And that's a large impediment to alternatives. So what you're seeing, it's very interesting to see what's occurring. As hospitals have consolidated, have become monopolistic and oligarchies, they have commanded more money. What the hospitals will do is, we know Medicare rates are fixed, Medicaid rates are fixed. That means the hospital goes and says to the private payers, increase my reimbursement rates. The insurer says, well, if I increase my reimbursement rates, my premiums will go up. The hospital says, if you don't give me a higher rate, I'm going to cancel the contract and you're going to pay me usual and customary. The insurer then says, well, I'll pay you more. What are hospitals doing with that more? They will tell you they're reinvesting. Well, we got to look at what they're reinvesting in. Hospitals become major sources of venture capital for new healthcare ventures, even though 9 out of 10 fail. And if you look at what's going on, many of these initiatives by hospitals, multi-million-dollar initiatives, are failing. They're investing in these businesses. And as I think we've seen, they're investing in advertising. Two things that have nothing to do with delivering care faster, better, and cheaper. So we have to do something to break that control so that money is available to invest in the lower cost, least restrictive care. Hospitals also using that money to enhance their monopoly position, buying more physician practices, buying ambulatory surgery centers. Now it's, let's buy urgent care centers so that we can control. And the issue of control is, they'll argue, oh, it's for a system. We're going to have an organized system. What it really is more about is capturing downstream revenue, with the idea that any patient that hits their system has an opportunity to deriving revenue from it, not only with the initial visit, but with the lab work, the radiology work, ambulatory surgery if they need it, and of course, hospitalization if they need it. I would argue that given where we are with technology, communications, shared electronic medical records, the ability to create a system in the absence of ownership control is tremendous, which would give us the opportunity to do some redesign. So I think I got a little bit far off your question, and I apologize for that, but you didn't stop me, so I kept going.
Well, I mean, I think that it's good for our listeners to have this background. I mean, I'm in private practice, and I know that in physical therapy, we talk about this issue all the time. How do you keep the doors open? How do you help patients who maybe can't meet their copay? What are some things that you need to do in the community? I mean, as a business owner, that's a hard decision to make, because you always have to think about, well, I have money to stay open, but I still want to be of service to this person that I've known in my community for years and years and years. So how can I adjust and improve this? And I think it's even worse as you mentioned, in the physician world. I mean, you don't see very many private practices as far as physicians go. A lot of them are being bought up by the big hospitals. And again, that gives the consumer less access and less choice when it comes to their insurance plan. I'm interested to know about giving us an overview about the status of medical debt for various stakeholders. I know you gave us a pretty big picture idea of kind of how hospitals and these big managed care systems are affecting healthcare in general. But what have been some developments that have contributed to it being in its current state that you haven't already mentioned?
So when it comes to the area of medical debt is a debt of necessity. It's not a person going out and buying a big screen TV that they can't afford it. They're acquiring that debt to protect their health or their loved one's health. They also are acquiring debt because they're exposed to inappropriate business practices within the medical community. These are the things such as the non-contracted physician who has a monopoly to run the emergency room, or the radiology group, or the pathology group at a hospital, these out-of-network providers who have become exploitive. And those stories are just rampant and tremendously sad. But what you have is, as health benefits have changed, higher deductibles. We've always had a group of people who have been uninsured and not eligible for Medicaid. We've always had that. What we've done, though, with health reform is we've shifted things dramatically. First off, we reduced dramatically the number of people who were not eligible for Medicaid. So Medicaid eligibility went up, tremendous coverage availability for Medicaid low income. Right? What we really have hit now is the middle class. The middle class has been caught with gaps in coverage, high deductibles, which are doing a job on them, and limitations on their benefits. There we go. Limitations on their benefits, which has put them in a position where they are exposed. Now, because of health reform, Obamacare, actually hospitals are having less charity care, what they call charity care, because that low-income individual, the individual that now qualifies for Medicaid, no longer is looking for charity coverage. Where the hit is for individuals, low middle class, even upper middle class, who are being significantly exposed to medical costs above their ability to afford it. And that's really what that comes down to. If you're looking at it, we have this country have over $1 trillion worth of medical debt that's out there. So just go back. So what is occurring is when a person can't pay their bill, there are several things that occur. A private practitioner, such as yourself, is looking at that individual, hopefully having a conversation, perhaps setting up a payment plan to accommodate them. Other situations, it's you owe this money, I need this money, I'm going to turn you over to collection, go get the money. Now, what's interesting in the world that we deal with is the bulk of the medical debt that's out there and being actively pursued is really being generated at the hospital level and at the ER group radiology level, not the practitioners who are, shall we say, readily touching patients, such as yourself and as a physical therapist. It seems to be the providers of care who are removed from as much direct patient contact. To them, this is a business arrangement. What we're doing in RIP Medical Debt is we're stepping in because these organizations take that debt, turn it over to collection, and then the CFO of the institution comes up with a brilliant idea. I can't collect it. The collection company comes back and says, I can't get this money. So they take these piles of debt and they sell it. They sell it for pennies on the dollar. They sell the right of some other party to collect it at full face value. What RIP Medical Debt is doing is we're going into the market and we are buying these portfolios of consumer medical debt for pennies on the dollar. And we are, instead of pursuing it for collection, are abolishing it and just wiping it out. We notify the collection company, if there is one. We notify the credit reporting bureau, and we notify the patient. This debt has been abolished. And because we are a 501c3, actually the IRS considers us, quote, pure at heart, which allows us to abolish that debt without creating a tax liability for the patient. Now, this is an interesting piece about medical debt and debt forgiveness. Technically, if you forgive a debt, the economic value of that forgiveness is actually taxable to the patient. So if a practitioner writes off a medical debt, theoretically, they should be sending a 1099 to the patient for the value of that debt forgiven, which would be taxable. Practitioners don't do it. I mean, it's not being done in the norm. But when you're an organization such as ours, there's a certain level of exposure we are exempt from creating a tax liability for the patient. Now, what becomes important for the people involved? Well, we can't abolish and don't abolish an individual by name's debt. It's a random act of kindness where we'll buy the entire portfolio, right, and abolish whatever's in there. Now, remember, what we're abolishing is debt that has been sold largely by hospital. So here you have organizations that are licensed by a state for a mission to provide care and concern for a community that's now has taken their debt and sold it to somebody for pennies on the dollar who's coming after it for the full face value. It's an interesting little twist. We're then abolishing it. So for the patient, it's being relieved. Now, what are we learning? When debt has been sold and it's gone through the collection process, it's been reported to the credit reporting bureaus. When your credit score is dinged, when it is reduced, we've learned several things. One, it affects your ability to get loans. it affects your ability to rent, to get a mortgage, or it increases the cost of doing so. But even worse, we're finding that 47% of employers are actually checking credit scores in the hiring process. So we actually have people who are being denied jobs because of poor credit scores that were created by debt that they accumulated to restore their health by a not-for-profit hospital in their community that expresses how much they are concerned about their local community. So when we take that off, we improve their credit score. Right? Additionally, when you advise someone that you've removed this debt from that burden, there's a psychological relief, a emotional relief for the individual. And what we're studying now is how much that is improving access to care. People who have medical debt have a tendency to avoid creating more, so they don't go when maybe they should. So this is what the burden we're trying to remove from people. Now, for the stakeholders who have sold this debt, they've already sold it for pennies on the dollar. They've gotten their pennies on the dollar. For the patient and the family economics, this is improving dramatically their situation. For the individual practitioner, actually what we found is we've had some physicians who've, some large groups that we've bought the debt from, and we've had those who've donated debt to us saying, please just take care of it. Now, our purchase of debt from a practitioner is not going to economically be a tremendous amount of money for them. There are other things that they are going to need to do. But our real focus is helping out the individual who has taken on this burden, has, quite frankly, potentially destroyed their own personal family economics because of their medical debt. That's really our focus. And we've had some interesting targeted groups in that. We've been able to identify individuals who are veterans and buy debt associated with veterans. And we've abolished about $65 million worth of veteran debt. Additionally, we have been able to abolish debt in specific geographic regions. And so we're trying to get better at our ability to identify the demographics. Our principal way of our acquisition now is by zip code. What we want to be able to do, and we've had some success at identifying debt based upon disease state, cancer in particular. So we're trying to get better at focus on that. But overall, these portfolios are a real mixed bag of medical debt that's come from a variety of sources. We'll buy it, we'll take it out of the market, abolish it, improving the lives of the individuals for whom we've purchased that debt for.
I love that it's kind of like a random act of kindness. It's something that I think I see this on Facebook all the time. People will post about how they were in their Starbucks line and somebody just randomly bought their cup of coffee, and just how good it makes them feel, even for something like that. I can't imagine what it would be like to get that envelope in the mail saying that all this medical debt that you've had for years and years has now been forgiven. How did RIP Medical Debt come into being? What is the story of this company? How was it created? How did you personally get involved with it, Robert?
So one of my co-founders and co-author with me on 2 books, Jerry Ashton. Jerry was hanging around at Occupy Wall Street down at Zuccotti Park. And Occupy Wall Street actually had a number of work groups that spun off. One of them was a group called Rolling Jubilee. Rolling Jubilee came up with this idea of buying medical debt and abolishing it. And they thought they would raise about $50,000, and they thought they could abolish $500,000 worth of medical debt. Jerry comes from the collection world. That was his business. He was in it. He was a bill collector. He was a bill collector of medical. And he thought this was the dumbest idea possible because, after all, that isn't even a rounding error, that kind of dollars. But the idea was intriguing, and so they wanted to pursue it. And Jerry, having that expertise, went to a friend of his, also in the business, Craig Antico, and said, why don't we reverse engineer what we do? What we used to do is we would acquire this debt and we'd go pursue it against the individual. Why don't we can, with this group, acquire the debt and abolish it? And that's what was done. I've known Jerry for many years, as I've said. We've co-authored 2 books at this point together. And he came to me, being in the healthcare end, to discussed the idea, and I was very much intrigued by it and what it could do. And at that point, Rolling Jubilee was successful. They abolished the $500,000 debt, terrific success. And then they said, we're done. We're not going to do it anymore. We're going to move on to something else. And Jerry's there. Gee, this is too good of an idea to give up. So Craig, Jerry, and I created RIP Medical Debt. And it limped along. I think the first couple of years we abolished maybe $3 million worth of medical debt. And then Jerry and I came out with our first book, which is called The Patient, the Bill Collector, The Patient, the Doctor, and the Bill Collector. And I had lunch with an attorney, a friend of mine for many years, and I gave her a copy of the book. About 2 weeks later, she got a phone call from the attorneys at HBO. They had a problem. John Oliver of the John Oliver Show Last Week Tonight with John Oliver had acquired the rights to $15 million worth of medical debt that he wanted to abolish. And the attorney said, should we be involved in doing that? After all, we're in the entertainment business. What do we know? And so the HBO attorneys were concerned about this thing called HIPAA. So they called the attorney I had lunch with, who sat there and said, well, she had the book on her desk, pulls up, she says, I got the answer for you. That was on a Thursday. By Monday, we're in the HBO offices. And they vetted us completely and said, okay, here's the deal. You're going to abolish the $15 million worth of debt for us. We go, great. We're most happy to do it. And the John Oliver Show kicked off, did an episode on this. We received, our name was mentioned 3 times, RIP Medical Debt. And our logo was on the screen for 9 seconds, just 9 seconds. From there, this thing has exploded. And when I say exploded, I mean exploded. Our website crashed. I mean, we couldn't field the phone calls. No one expected it. From there, the volume of kind of one thing leading to another, to another, to another just continued. It's been tremendous. So the story, John Oliver got out there. The internet exploded. We had people who attacked us, which was very interesting. One of them, I mentioned this issue of the tax consequences of abolishing medical debt. Well, that became a big issue on the internet. Unbeknownst to us, this professor at Vanderbilt University wrote an article in the National Law Review online explaining why we were perfectly legal. Now, we knew it from our attorneys that we were, but here was another source. Well, that story got picked up again. We find ourselves, this is very interesting, with a couple of high school kids who saw the show, and the school required a social action project. So they took it on to abolish $1 million worth of medical debt. They're going to do bake sales and the like. Somebody in their community, Pensacola, Florida, saw an article on what these high school kids were doing, called us up and said, if they make the money to abolish $1 million, I'll give you the money to abolish $2 more million. Go, oh, this is nice. That story got picked up. That story then we ended up on NBC Universal, which gave us money to abolish another $12 million worth of medical debt. Cox News, Sinclair News. Right? In Texas, in the Dallas area, there was a evangelical church that spends $100,000 a year doing promotion for Easter service. They came to us, they said, here's the $100,000, what can you do? We're able to abolish $11 million worth of medical debt in their service area. The minister announced at Easter service, he said the press they've gotten on that donation to us, on the $11 million, got them more publicity, better goodwill than they could have ever bought for the $100,000 worth of advertising for Easter. Well, not only that, but every religious publication picked up the story. And he called us to say he's just overwhelmed by the publicity. And he said the best article written about it was in the American Atheist magazine. So from that, I mean, each one of these things, but I will tell you, we've had Melville Brewing donated the proceeds of an entire run of their ale to us. This is a good story. You'll like this one. A group of nurses in Michigan were having a labor dispute with their administration. So they got a hold of us and they gave us the money to buy $2 million worth of medical debt in their community. And what do you do as nurses? in this situation? You hold a press conference and they get up and they announce how they care about the community, how they love the community, how they're devastated at these horrible medical bills, that they themselves use their money to abolish $2 million worth of medical debt. And you know where that medical debt comes from? Those miserable hospital administrators, those same people that won't negotiate with us in good faith. The story was phenomenal. The trustee stepped in and ended the labor dispute. Then you have the other extreme. This one out of Action Jackson TV in Florida. We did the story, and when the channels do these stories, they open up a local campaign. And we received shortly thereafter the campaign, we received a letter with a check from an individual. And the fellow writes, he says, look at, my wife recently died of cancer. We had good coverage. I didn't suffer economic consequences. But in the process, we met many people who didn't have good insurance. Here's a check representing the proceeds of her life insurance, and I want it to be used to help other people with their medical debt. So you have incredible stories. We had two women up in the Finger Lakes area in New York that are promoting the idea. They have an organization that is lobbying for Medicare for all. They went out and they raised the money to abolish $2.5 million worth of medical debt. That ended up in the New York Times, that story. We had an anonymous couple give us the money to abolish $250 million worth of medical debt, which we did right before Christmas. But each one of these events just creates another public airing of the issue.
Yeah, it sounds like it has had a big snowball effect for you. And it sounds like how you're able to do this is mostly through donations. Is that correct?
That's correct. So the donations to us allow us to acquire the debt and then abolish it.
So how is that debt acquired? Like, do you go to these collection agencies and then you take the money that you've gotten from these donations and then you pay off these agencies and then you personally
similar. So there are individuals who go out and literally go from hospital to hospital, large medical group to medical group, and buy the debt buyers. And they buy these massive portfolios. And they then take that and they try to upsell it to collection companies to say, look, buy this bunch of paper and try to collect on it. You'll pay me 10, 12 cents on the dollar. And if you can collect, great. You take the risk. You're in the collection business anyhow. You got the excess capacity, go do it. We buy from the debt buyers. So our principal source is going to the large debt buyers and buying entire portfolios. Now, when we'll buy a portfolio, there are many things we learn about that. First off, about 30% of the debt that's in those portfolios should have been addressed at the hospital level. These are individuals that would qualify for really every hospital's charity program. Hospitals are not aggressively looking to give charity money away. Actually, the amount of charity care by hospitals in this country is dropping. It's been dropping dramatically. It's less than 2%. They're not responsive. They're not set up to it because how are hospitals promoting charity care? Well, generally, they throw up a sign in the emergency room or in the clinics and say, contact us. And quite frankly, many people don't know they have a problem until the bills start coming in. And even I deal with some people in my local community. We went through a situation with a hospital where we wrote them multiple times saying, hey, we'd like to apply. Actually sent them the qualifying letter from another hospital the person was in, and they ignored it. They ignored it multiple times, ended up turning the individual over to collection because they didn't care. That's not what they're involved in. This is an annoyance for them. Right? That's one thing we learned. Second thing we learned is a lot of this stuff is old, that literally should not be out there. But there's a very fascinating thing about collections in this country. There is nothing by law that precludes an individual collection company to try to collect on a claim that is past statute. So the bill is 6 years old and by that state statute is no longer legally collectible. That does not preclude somebody from calling and trying to get the money. There's a great line that came out of a woman actually at United Healthcare who's involved in recovery of funds. And her comment to me when I pressed her on this, she said, just because we can't legally take the money back doesn't mean we can't ask for it. After all, people should know the law. Well, how many people getting a letter know that difference. Know that they don't, that they don't have to pay it, that they can write back, this is past statute, leave me alone. They don't.
Yeah, I think people really panic when they get these bills in the mail and they say, "Oh my gosh, like I didn't even realize that this bill was still out there." They don't want to damage their credit score. They want to have access to these things a mortgage, to be able to rent. So I can definitely see when you talk money, people's brains shut off.
But I look at sad situations. I work with people in my community who are returning to the workforce after alcohol and drug abuse. And they've gone through rehab, gone through our halfway program. We've now gotten back into jobs. So some of the, can be years and years later. And I went through one not too long ago where the individual, we've gotten them, they're working in a warehouse, they're now employed, great, terrific. And out of the blue comes a bill that is 8 years old demanding payment. Now he has an income. He's not legally obligated to pay it, but does he know that? Fortunately, he said, I got this, what do I do? I said, hey, we'll write this little note and send it back to him. But if you don't know that, there is nothing that stops an individual from asking for money back. And remember, these letters don't ask nicely. They don't say, oh, please, by the way, if you have a couple extra spare $200 to send us. They are very formal. They are threatening. They may exclude the lines that they're not supposed to say, such as if you don't pay it, we will be able to garnish your wages if it's out of statute. But many of these collection companies send out the same kind of letters with the same kind of threats. I just got one on behalf of a hospital that I dealt with. And the letter said, we're pursuing you. And this was a 6-year-old letter claim. And it said, and we've notified you 4 times in the last 45 days. No, they hadn't, but they were using their standard recovery letter. So, what kind of happens at times, it's very interesting with practitioners. And it's something that we've urged and we've invited practitioners to give us their abolished claims, the things that people write off, so that we can bury it. Because here's what happens in many offices. A new practice administrator shows up and they're going to show how good they are. So they take that electronic file that's been sitting on the side, that all the write-offs, and go, I'm going to send out bills to all of them. Let's see what I can get, shake loose. Because you send it out, people's circumstances have changed, or somebody's feeling threatened, and they send those out. Many times they'll use the wrong collection letter, which, by the way, can get a practice into trouble under the Federal Fair Debt Collection Practices Act, violation of state laws, out of statute. By the way, if the letter is written the wrong way, it could even be considered mail fraud. Practitioners at times don't understand those nuances. So what we've invited individual practitioners to do, to literally give us that debt that they've written off so that it can't come back and haunt the patient or literally get the practice in trouble because a new practice administrator or new biller decides to go after things that are out of statute with the wrong kind of correspondence.
How would a practice give you those write-offs? Is that something that they mail to you? Do they talk to your lawyers? How does that work?
Just contact us through our website. We have people that one of our associates easily has a conversation with them and sends the file electronically.
In healthcare, we're all about data. We love our data. So I'm wondering, I know that you mentioned that you guys have kind of been trying to track who who the people are that you're forgiving this medical debt for. What data do you have that talks about how much debt you have forgiven for certain groups? Have you guys been able to collect that? Like, what is kind of the population that you guys target?
So let's talk. When we buy a portfolio of debt, we don't just abolish all of it. We actually qualify it. So the individual must be at 2 times the federal poverty level or below. Okay? Or they have to have debt more than 5% of their income or otherwise be insolvent, such as a bankruptcy or insolvency. So it isn't a matter of we buy it because somebody's and abolish it because somebody's very good at dodging bills that it's end up being sold. So we qualify that. In terms of the general groups, we really breakdown really is about $65 million of veteran medical debt. Those we can identify. And the rest is from the general population. Now, from on diagnosis basis, I don't know offhand the number that we've had related to cancer diagnoses because many a times these bills come in without portfolios don't have the diagnoses. But we're trying to get, that's where we're trying to focus some real data activity on. The bulk of it is, and I'm going to say about 90+% is hospital sold medical debt. Now, when I say hospital, that will be the acute care, outpatient, hospital employed physicians, hospital ancillaries, but the bulk of it. Because what you really seem to have is, again, you know this as a practitioner. You know the human being you're treating. That human being you view differently than the CFO sitting in office saying, how do I maximize revenue to this business? You're going, I look at my outstanding debt, I look at it, and I know the face that goes with the name. That CFO doesn't know it. He's going, I get rewarded for bringing in revenue. I'm going to bring in revenue. Let me sell it.
I think that's a big, it's a big problem in healthcare is how do you balance the business of healthcare, but also in remembering the humanistic aspects about why we all decided to become healthcare practitioners. And I think it's a huge problem, especially as these hospitals or as these smaller practices are being bought up by hospitals. Because now you have the accountant coming to you as a practitioner saying, why are you only billing this many units? You should be billing this many. But you as a practitioner are like, I can't bill that. I didn't see the patient that long, or I didn't provide that service. And so now you're kind of stuck in this scenario where you are deciding, okay, obviously I'm a humanistic practitioner. I can't go and lie about these charges.
Well, for a practitioner to be put in a position where somebody from administration wants them to falsify a claim, that's fraud. That's wrong under any circumstances. The difference that comes in that I always found with the practitioner in private practice is the argument of the heart and the head. The heart says, I know this human being. I know what they're going through. Therefore, I am going to write it off. I am going to discount it. I am going to look for a lower cost provider for their laboratory and the like. I'm going to try to help them. My head says I have to maximize my revenue to stay in practice. Now, this is why, this is the reason why physicians and other practitioners leave certain geographic areas. Because, it's sad that what's really come down to is patient mix. When I was putting together my Medicaid plan, and I was the first Medicaid managed care plan in the secondary market in New York, I went to the physicians that we had in our commercial medical HMO, and I told them I wanted to do it, and I asked them if they would participate. Not one physician turned me down, but they had a couple of requirements. Why had they stopped taking Medicaid? Because Medicaid said that if you participate with Medicaid, you have to take every Medicaid patient who walks in your door. Well, if you bring in too many Medicaid patients at what Medicaid was paying, you couldn't afford to keep your doors open. Secondly, they wanted to be paid something, wasn't the highest commercial rate, but something reasonable. And they didn't want the bureaucracy. We said, fine, but not one physician turned me down as long as they could limit. We asked them to see at least 10% of their commercial volume that they had with us in Medicaid. But this is what occurs because practitioners went into delivering care to be a caregiver, to provide for people in the community. They've been forced by the economics to make certain decisions, many of which they themselves don't like. And it hasn't been, let me just maximize every single dollar. It's, I'll take a range. I'll accept a certain amount that I would write off or that are Medicaid. But if my neighborhood, my geographic area means that I have 60% Medicaid, I can't afford to keep the doors open, so I leave or I become an employee of somebody.
There's a similar situation going on in the student debt arena.
Yes.
Are you aware of any organizations across the country that do something similar to this, along the same lines as RIP Medical, but for other avenues such as student debt?
So I know there's an awful lot of conversation about it. We have had some discussions with people who would like to use our structure for doing just student debt. We can acquire any debt whatsoever and abolish it on the same kind of basis. One, is student debt being sold? So, because this becomes where we've had the advantage is that medical debt is sold for pennies on the dollar, which allows us to buy it and really make leverage the dollar. If student debt is sold on a discounted basis, the same thing could occur. As I said, we've been approached of whether or not we could do it. Technically, we can. We've not moved in that direction. It's just not where our background is, our knowledge is. I haven't found anybody who's doing the same thing in student debt, but I've come across a lot of different programs. So, there are certain states that are providing forgiveness programs. If you live in that state, if you work in certain communities, if you'll take certain jobs, it's somewhat like I have this conversation many times with people going into medical school and avoiding the debt. There are terrific programs to avoid going into that debt. There'll be the military options. There'll be the public health options, the Indian Health Bureau. So there are many programs. I think what's important for people who are facing, how do I pay for education, whether it's medical school education or higher education, all, is to come up with a game plan, not willy-nilly go, oh, I'm just going to take on the debt and worry about it later. So, my own experiences that I've seen is, it's the 2 years of junior college to keep the cost down. It's the, let me get in because schools don't like to lose students, so they're going to come up with student aid. Okay, let me do the military option where the National Guard is providing money. I think we have to be on all of our debt avoidance thoughts, much more planning. If you have yourself a $2,000 deductible in your health plan, let's plan for it. If you have it, no one's going to want to use it, but isn't it better to slowly over time build up that money, those reserves? It's the financial planning guidance that says you should try to build up, 3 months worth of living expenses? We just saw with the shutdown, federal employees who were, these are individuals who are employed, gainfully employed, going to food banks. Now, I'm glad that they could. I think it's tragic they're put in that position. But I would hope, and I know it's hard, but you can save 10% of anything if you just pay attention. So if people were to pay attention and just keep putting a little aside and a little aside, they could avoid that exposure on a deductible situation for any insurance, medical included, and we have to plan out what's going to occur for education. I think we have to think of it differently. There was a time when in the ancient days when I went to school, taking on debt, it was cheap, it was easy, and it wasn't much because school bills weren't that much. But trying to plan ahead of time to avoid that, in my mind, is the best bet, whether it's medical or student.
I think that that's where a budget comes really in handy. I know for me personally, I was never really taught to handle money by my parents. And a lot of what I learned happened after I got my first job. And my former boss actually taught me, have a budget, make sure you're saving. And it has really helped me feel a lot less stress. I feel like I have a good management of my student loans, but a lot of times it just takes that person to help teach you to make a budget and make sure that you are saving for some of those emergencies that do come up. As far as student loan goes, most student loans are backed by like the Federal Reserve. So even if somebody doesn't pay on them, the student loan company is guaranteed to be paid back by the government somehow. Is that something that affects the reason or ability for a company, say like RIP Medical Debt, to buy up some of that debt because that money is almost always guaranteed? Or what is kind of your thoughts on that?
We haven't looked deep into it. And if it's so the problem with federally guaranteed debt is that mean the debt is owed by the federal government. I haven't seen the federal government putting it up for sale the way commercial businesses do. Either they will pursue it. I think if I remember the last time I looked into this, if you're a federal employee and you have federally guaranteed unpaid student debt, they're very happy to garnish your wage, or preclude you from getting other federal benefits if there's an outstanding federal loan. One of the problems about debt is, whether it's student or medical, is that whole you have been bad. you are wrong. The debtor is wrong. The debtor is, there's something wrong with you that you owe money. And I have a great deal of problem with that thought process. If you look at rising education costs, rising medical costs, both of those are outrageous what they are now costing, which is forcing people, we say in America, the best way to improve your family's well-being is education. Well, you may have to go into debt to get that education. Well, maybe the job market wasn't as kind. Maybe it wasn't. Or, what I find very repugnant, and we've seen a crackdown on them, are the proprietary colleges and these technical schools that exploited the federally guaranteed debt. So you saw this with some of these private technical schools, where it's come on in, student, won't cost you a thing, where literally a sales job was done on these individuals. Come, you'll take this, don't worry, it's all financed, no problem whatsoever. And one, the quality of the education may be suspect. Secondly, these individuals weren't counseled. They were basically told it's a free ride, no problem, don't worry about it. And there was something, I wish I could remember better, but there was a private college or law school which had incredibly low employment rates after graduation and very high bar failure rates. But that information wasn't being made available to the people entering the school. So you're sitting and saying, oh, but don't worry, you'll take a loan, and after all, you'll get out, you'll be an attorney and look at the money you'll make and you'll pay it off without a problem. Well, the only way you pay it off is if there's a job and a job able to pay. So this whole thing it's really kind of cockamamie what we've done. And the parallels that I find as I talk to people of education and healthcare are so similar. They're both industries that basically have said, give me money, give me money, give me money. And if you give me less, quality will go down. And by the way, trust me, I'll do the right thing with the money you're going to give me. And it hasn't turned out that way in either of those industries. And and we don't share information, and we don't want accountability, and we don't want statistics about our performance out there. The similarities are absolutely fascinating, distressing, but fascinating.
Yes, I totally agree. And we have so many people that listen to this podcast that are that have a lot of student debt from going to medical school or going from physical therapy school. And managing that can sometimes be challenging. At the end of all of our podcasts, Robert, we ask a standardized question. Mm-hmm. And that is, if you could change one aspect of healthcare education, what would you change and how would you change it?
I mean, there are two pieces that play out. Actually, there's several. When you say healthcare education, in the healthcare education area for the medical providers of all kinds, we have to instill a knowledge of basic nutrition that can be integrated into care treatment plans. I just looked at the figure. Actually, my wife, as we were driving by a Kentucky Fried Chicken, reminded me that there was a study out that consumption of fried foods reduces lifespan. I think they were saying 13 years or something like that. Having me swear off that I will never step into KFC again in the process. But if so much of health is related to well-being of the individual, let's start. Our obesity rates. Our high blood pressure rates, these are nutritionally related. When I was doing as a dialysis technician, I had a patient in a home situation who literally maintained her diet to such a degree that she was able to eliminate one dialysis treatment a week, from 3 down to 2. Look at what this does in terms of health quality improvement and lowering costs. That piece. Nutrition is not built into the education of practitioners, and yet they have a tremendous opportunity to influence the patient. But it has to go deeper than just dropping it on the practitioner's lap. For the public, the self-care, the self-awareness of one's health, of understanding of what they need to do to be part of improving their health. But the other factor I'm going to say is self-education has to include an understanding of your health insurance plan, your health benefits, what a network means, what in-network means, and how to watch out for being exploited in that process. That is the okay.